The principles of medication dosing in children. Medication dosing in children requires a fundamentally different approach than adult dosing because pediatric patients undergo rapid and dynamic physiological changes that profoundly affect how drugs are absorbed, distributed, metabolized, and excreted. Children are not small adults. They have unique pharmacokinetic and pharmacodynamic profiles that evolve with age, organ maturity, and developmental stage. Individualization is key. Individualization or personalized medicine is the cornerstone of safe and effective medication dosing in children. Unlike adults, children undergo continuous physiological changes throughout their development, meaning that drug absorption, distribution, metabolism, and excretion can vary dramatically from one age group to another. Because of these differences, children are not simply small adults, and standard adult doses cannot be applied proportionally. Clinicians must carefully adjust doses based on several critical factors, including the child's age, which influences enzyme activity and organ maturity, weight, which determines the relative amount of drug exposure, body surface area, which is particularly important for medications with narrow therapeutic windows, such as chemotherapy or certain cardiac drugs, and organ function, especially the maturity of the liver and kidneys, which governs drug metabolism and clearance. Considering these factors in combination allows for a truly individualized approach, optimizing therapeutic effect while minimizing the risk of toxicity, and underscores the need for continuous reassessment as the child grows or develops medical conditions that may alter pharmacokinetics. Age-based considerations. In the neonatal period, from birth to 28 days, liver enzyme systems and kidney function are immature, resulting in slower metabolism and reduced drug clearance, which increases the risk of accumulation and toxicity if standard doses are used. During infancy, from 1 month to 12 months, rapid growth and maturation of metabolic pathways mean that drug handling can change markedly over weeks and months, so dosing must be frequently reassessed. In early and middle childhood, from 1 to 12 years, many children metabolize certain medications more quickly than adults, and per kilogram doses for some drugs may actually be higher than adult equivalents. This reflects higher relative liver metabolic capacity and increased renal clearance in this age range. Adolescents, from 12 to 18 years, approach adult physiology, but puberty introduces hormonal changes that can alter body composition, drug distribution, and requirements for particular agents such as insulin during growth spurts. Clinicians use several common dose calculation approaches in pediatrics to ensure both safety and efficacy. The most widely used is weight-based dosing, typically expressed as milligrams per kilogram per dose or per day, which depends on an accurate, recent weight in kilograms and always includes verification that the calculated dose does not exceed recommended maximum adult limits. For medications with narrow therapeutic windows, such as chemotherapeutic agents, anticonvulsants, and certain cardiac drugs, body surface area dosing using validated formulas, such as the Mosteller method, provides greater precision. Age-based dosing may be applied when weight is unknown or in standard immunization schedules or combination products, though it is generally less precise than weight or BSA-based methods. Safety considerations are paramount. All calculations must be double-checked, ideally by a second clinician. Oral syringes or calibrated measuring devices should be used for liquid formulations, and the child's developmental abilities, such as the capacity to swallow pills, must guide formulation choice. Organ function, especially hepatic and renal maturity, must be continually reassessed in neonates and infants, and special populations such as preterm neonates. Children with obesity and oncology patients often require tailored dosing strategies with careful therapeutic monitoring. Liquid formulations are preferred in younger children, and when licensed pediatric formulations are not available, compounded or age-appropriate preparations may be necessary, with attention to excipients and bioavailability. A systematic dosing process, converting weight to kilograms, identifying the correct dosing strategy, calculating the dose, checking maximum limits, selecting the appropriate formulation and frequency, and closely monitoring for therapeutic effect and toxicity, ensures optimal outcomes. Recent evidence in pediatric pharmacotherapy continues to reinforce the importance of individualized dosing. Advances in physiologically based pharmacokinetic modeling to predict age-related drug behavior, and the expanding role of electronic dosing support tools to reduce errors and improve safety in pediatric medication management. Weight-based dosing. Weight-based dosing is the most common approach in pediatric pharmacotherapy, as it allows drug doses to be tailored to a child's body size and physiological capacity. Most pediatric medications are calculated in milligrams per kilogram of body weight, using the straightforward formula. Dose in milligrams equals the child's weight in kilograms multiplied by the recommended dose per kilogram. This method ensures that each child receives an appropriate amount of medication relative to their size, optimizing therapeutic effects while minimizing the risk of under- or overdosing. However, clinicians must always cross-check the calculated dose against the maximum recommended adult dose, as exceeding these limits can lead to toxicity, particularly for drugs with a narrow therapeutic window. Accurate, up-to-date weight measurements and careful calculation are therefore essential components of safe pediatric prescribing. Body surface area, BSA, dosing. Body surface area, or BSA, dosing is an important strategy in pediatric pharmacotherapy, particularly for medications with narrow therapeutic windows, such as chemotherapy, certain cardiac drugs, and potent anticonvulsants. BSA dosing accounts for both the child's weight and height, providing a more precise estimate of the body's metabolic capacity than weight alone. The most commonly used calculation is the Mosteller formula, where BSA in square meters equals the square root of the product of the child's height in centimeters and weight in kilograms divided by 3,600. Once the BSA is determined, the drug dose is calculated by multiplying the prescribed milligrams per square meter by the child's BSA. This method helps optimize drug efficacy while minimizing the risk of toxicity, making it especially valuable in high-stakes treatments where precision is critical. Organ maturity considerations. Organ maturity is a critical factor in pediatric medication dosing, as the liver and kidneys, the primary organs responsible for drug metabolism and excretion, undergo significant development during childhood. In neonates, liver enzyme systems are immature, leading to slower drug metabolism and an increased risk of accumulation and toxicity, as historically seen with chloramphenicol, which can cause gray baby syndrome if dosed inappropriately. Similarly, renal function is not fully developed at birth. Glomerular filtration, tubular secretion, and reabsorption mature gradually over the first year of life. This means that medications primarily eliminated by the kidneys, such as aminoglycosides or certain antibiotics, require careful dose adjustments in neonates and young infants to avoid toxicity while ensuring therapeutic effectiveness. Recognizing these developmental changes and incorporating organ maturity into dosing decisions is essential for safe and effective pediatric pharmacotherapy. Pharmacokinetic principles. Understanding pharmacokinetic principles is essential for safe and effective pediatric medication dosing, as the absorption, distribution, metabolism, and excretion of drugs differ significantly from adults and change with age. In neonates, gastric pH is higher, which can affect the stability and absorption of acid-labeled drugs, and gastric emptying is slower, potentially delaying peak drug concentrations. Distribution of medications is also altered in children. They have a higher total body water content, which may require higher milligram per kilogram doses for water-soluble drugs, and lower fat stores, which can reduce the volume of distribution for fat-soluble agents. Metabolism varies with age because hepatic enzyme activity matures over time. Some drugs may be metabolized more rapidly in older children than in adults, while neonates metabolize many drugs more slowly. Excretion, primarily through the kidneys, also matures postnatally, with glomerular filtration and tubular function increasing as the child grows. These pharmacokinetic considerations are critical when calculating doses, selecting formulations, and monitoring for both efficacy and toxicity across different pediatric age groups. Safety principles. Safety is paramount when prescribing medications for children, as they are particularly vulnerable to adverse drug effects. Clinicians must avoid drugs that are contraindicated in specific age groups, such as promethazine in children under 2 years due to the risk of severe respiratory depression. Attention should also be paid to excipients in pediatric formulations, including substances like propylene glycol or benzyl alcohol, which can be toxic in neonates and young infants. For drugs with a narrow therapeutic index, a cautious start low, go slow approach should be applied, carefully titrating doses while monitoring for both therapeutic effect and signs of toxicity. Adhering to these safety principles helps ensure that pediatric patients receive effective treatment while minimizing preventable harm. Formulation and administration. Formulation and administration are critical considerations in pediatric medication dosing to ensure accuracy, safety, and adherence. For younger children, liquid formulations are generally preferred, as they allow precise dose measurement and are easier for children to swallow. Accurate measuring devices, such as oral syringes or calibrated droppers, should always be used to avoid dosing errors, which are more likely with household spoons or approximations. Tablet splitting should be avoided unless the medication formulation explicitly allows it, as altering tablets can change drug bioavailability and result in inconsistent dosing. When pediatric-appropriate formulations are unavailable, compounded preparations may be necessary, but careful attention to stability, excipients, and dosing accuracy is essential to maintain safety and therapeutic efficacy. Monitoring. Monitoring is a critical component of pediatric medication management to ensure both safety and efficacy. Clinicians should continuously assess the child's response to therapy, tracking therapeutic effects as well as early signs of toxicity. Doses should be adjusted over time as the child grows, or if there are changes in organ function, particularly liver and kidney maturity, which can significantly alter drug metabolism and excretion. For medications with narrow therapeutic windows, such as digoxin, aminoglycosides, and certain anticonvulsants, therapeutic drug monitoring is essential to guide dose adjustments and prevent adverse effects. Regular monitoring ensures that the medication regimen remains both effective and safe throughout the child's development. Key takeaways. In summary, pediatric medication dosing is a dynamic process that must be tailored to each child's age, weight, developmental stage, and organ function. Clinicians must carefully consider factors such as organ maturity, pharmacokinetics, and potential safety risks, including drug-specific contraindications and excipient toxicity. Accurate measurement, appropriate formulation selection, and ongoing monitoring for therapeutic efficacy and adverse effects are essential to ensure that children receive safe, effective, and individualized treatment. By adhering to these principles, healthcare providers can optimize outcomes while minimizing the risk of medication errors or toxicity in pediatric patients.